High blood pressure is a silent killer, a leading cause of heart attacks and strokes, and costs the US approximately $131 billion a year. So what's wrong with ensuring that doctors are held accountable for controlling blood pressure by creating a quality measure? Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal. I'm a primary care physician in Connecticut, and I run my own medical practice. The controlling blood pressure measure is a great political slogan. However, it is a misinterpretation or misrepresentation, depending on your point of view, of the real story behind these preventable heart attacks and strokes. Instead of understanding the true complexity of poor outcomes, the medical industrial complex created a simplistic metric that serves profits over patients. Let's dive in. The controlling blood pressure quality measure specifies the percentage of patients 18 to 85 years of age diagnosed with essential hypertension whose most recent blood pressure was adequately controlled, that is less than 140/90, during the measurement period. Let's break down the quality measure into its individual parts. First is the denominator, which defines the total number of eligible patients, which is everyone between age 18 to 85 years. Next is the numerator. Only the last blood pressure of the year is used for the numerator. The blood pressure should be less than 140/90. Then we have denominator exceptions. In this case, people are removed from the denominator only if the examining doctor justifies that it's not medically appropriate. Examples include hospice or palliative care, end-stage renal disease, dialysis or renal transplant patients, pregnancy, 66 to 80 with an indication of frailty plus an advanced illness diagnosis, taking dementia medications, or 81 years and older with an indication of frailty, 66 and older and living long-term in a nursing home facility. Next is the reporting period, during which the quality measure applies. This is generally between January 1st to December 31st. And the last are data sources that will be used to calculate the quality metric. That is, which blood pressure value documented in the medical chart can be used to qualify the patients in the numerator. The rules around which blood pressure will be accepted is where we start getting into the nitty-gritty details. According to the NCQA, only the following blood pressures can be used to count as a numerator. Blood pressures performed by a clinician. If the patient takes a blood pressure, they must use an automated blood pressure monitor, and the blood pressure machine should be capable of remote transmission of blood pressure data, and it should be conveyed to a clinician. If multiple blood pressures are documented, then we use the lower systolic and diastolic numbers. That is, if a person had two blood pressure readings, for example 130/100 and a repeat reading of 150/80, the patient qualifies for the numerator as one reading had a systolic of 130, while the second reading had a diastolic of 80. Blood pressure readings taken during an acute inpatient stay or an emergency department visit should not be used. And if no blood pressure reading is recorded during the measurement period, the patient's blood pressure is automatically assumed that it is not controlled. The last point wreaks havoc on PCPs, and I will discuss this in detail later. The rationale for controlling blood pressure quality measure is because several medical societies recommend a target of less than 140/90. Now, let's take a look why this rationale is wrong. The fact that uncontrolled hypertension leads to excess heart attacks and strokes is indisputable. The powers to be want you to believe that doctors are not doing the job of controlling blood pressure, and as with any profession, there are a few bad providers. However, the root cause of uncontrolled hypertension is much more complex and rooted in social determinants of health, which we as a country have decided that we are not going to pay for. So the medical industrial complex does the next best thing: blame doctors, create a quality measure, and laugh their way to the bank under value-based care. By the way, if you want to learn more about how value-based contracts are structured, please watch my prior video on value-based care and the illusion of improvement. How do I know that these majority of adverse events from uncontrolled hypertension are due to social determinants of health? Well, I looked at the articles cited by NCQA in their rational statement. By the way, you can find these references to these academic articles in the written newsletter version on pcplens.com. So, NCQA's central thesis states that uncontrolled hypertension leads to a higher risk of cardiovascular disease and higher costs. What NCQA ignores are the social determinants of health factors that lead to uncontrolled hypertension, factors such as income, occupation, education, isolation and loneliness, neighborhood safety, working two jobs, and access to healthcare. The corollary to this arguably is, if you control for these social determinant of health factors, the vast majority of patients with private insurance seen at a private practice their hypertension is actually pretty well controlled. Furthermore, these same social determinant of health factors also lead to other behavioral choices and medical problems such as smoking, poor diet, obesity, diabetes, lack of exercise, high cholesterol, etc., which in turn increases the risk of cardiovascular disease. And yet, the NCQA wants to hold your humble PCP responsible for controlling blood pressure to a target of 140 by 90, because we as a country don't want to think about and address the systemic social challenges. And if that was not enough, next I'll show you how forcing this quality measure in doctors, NCQA is doing more harm by turning a guideline into a rigid rule. First and foremost, the controlling blood pressure quality measure penalizes doctors trying to manage tougher populations with social determinant of health-related challenges. Example, the homeless, those with low health literacy, or those who even distrust the health system. So if a doctor successfully lowers the systolic blood pressure from 200 to 160 in these populations, they dramatically lower the cardiovascular risk. However, since the systolic blood pressure 160 is still considered uncontrolled, that is it's still over 140, these doctors are penalized, which may lead to financial penalties, burnout, or both. This is the target population that we need to concentrate more on improving cardiovascular outcome. We penalize doctors who take care of these people, the opposite of its intended effect. Next, the risks and benefits of blood pressure control arguably follow the J-curve effect. This refers to the phenomenon where lowering blood pressure too much, particularly below a certain threshold, may increase the risk of adverse cardiovascular events by reducing blood supply to critical organs. Paradoxically, this can be worse for people who are sicker with multiple comorbidities and taking multiple medications, as aggressive blood pressure lowering may increase the risk of heart attacks and falls leading to hip fractures. There is an ongoing debate on what blood pressure is considered too low for optimal cardiovascular outcomes, with the joke being the best blood pressure is just before you pass out. The SPRINT trial reasonably showed that lowering systolic blood pressure to less than 120 does reduce all-cause mortality, albeit with the increased risk of medication-related side effects. Since SPRINT excluded people on multiple medications, the incidence of side effects from aggressively lowering blood pressure is probably higher in clinical practice. Now, you may be wondering why I'm talking about lowering systolic blood pressure to 120 when the quality metric target is lower than 140/90. The reason is that this quality measure checks all the boxes of why quality measures don't work, which I discussed in my prior video, the quality of quality measurement, including changing a medical decision from complex domain to simple domain of the Kuhneven framework, Goodhart's law, and Charles Per's theory of normal accidents. In real life, this has three major effects. Doctors become over-aggressive at prescribing blood pressure medications if blood pressure is elevated in the office, instead of checking if the blood pressure is normal at home. Under-prescribing blood pressure medications once a target blood pressure 140/90 is reached in people that may benefit from further lowering of their blood pressure. Both over and under-prescribing pushes people towards the ends of the J-curve, leading to side effects or suboptimal outcomes. And lastly, the practice may discharge patients from the panel if they are either not taking the medications or in more unfortunate situations are unable to afford medications. SMART criteria are often used to ensure that the objective is clearly defined and attainable. Let's apply the SMART criteria to the blood pressure quality measure. The first one is specific, and the measure has specific criteria, including a target of less than 140/90, age between 18 to 85, and a diagnosis of hypertension. Next, the metric should be measurable. And the quality metric is technically measurable, but there are several nuances, especially which blood pressure value should be counted and included in the numerator. For example, in which setting should the blood pressure be taken? Example, in the home or in the doctor's office? Who should take the blood pressure to ensure accuracy? Example, the patients themselves or the medical office staff or the doctor? Which blood pressure reading should we use? Average of all blood pressure readings taken throughout the year? Blood pressure taken only on office visits in which the ICD-10 code of hypertension was billed? Or the last reading of the year? Next, the metric should be achievable. Achieving a blood pressure control of 140/90 is definitely achievable. However, this may be more difficult or not possible without inflicting harm in some populations. For example, people with white coat hypertension, orthostatic hypertension, or white pulse pressure. Next, the metric should be relevant. While there's plenty of data to show that lowering blood pressure decreases the risk of cardiovascular morbidity and mortality, however, due to the J-curve effect, blood pressure targets may not be generalizable to the entire population as mentioned in the previous slide. The measure is time-bound, as it evaluates blood pressure control within the measurement year. However, the reliance on a single reading rather than ongoing control over time limits its ability to assess if it will improve patient outcomes. One of the central challenges in blood pressure management is the infamous qualifying encounter rule. Only a blood pressure taken during a qualifying encounter can be used to credit the PCP that they kept the blood pressure under control. The qualifying encounter visit type is an outpatient encounter where no major procedure is done that day. It should be billed to the insurance company, and only the last visit of the year counts. And if that wasn't enough, if a blood pressure is not checked during the last visit of the year, then the PCP is considered non-compliant. Unfortunately, the last quarter coincides with winter, at least here in Connecticut, bringing waves of respiratory infections and injuries due to people falling on ice. So we've created a perfect storm to ensure that PCPs fail this metric. PCPs see more sick people, whose blood pressure readings may be unreliable due to their illness, and staff shortages due to sick staff, which can lead to skipping blood pressure checks in patients not coming in for hypertension follow-up. Therefore, if the blood pressure is high during this encounter or the blood pressure was not done for safety reasons, your humble PCP fails the quality measure, even if the blood pressure was controlled throughout the year. Let's take a look at some real-life examples on how PCPs can fail the quality measure even if the person's blood pressure has been controlled throughout the year. The patient has a sick visit with PCP for COVID-19. Blood pressure is not checked due to safety reasons. A telehealth visit is done either by video or by phone for a sick visit where blood pressure is not documented. There's an orthopedics visit for severe ankle sprain after a person fell on ice. Blood pressure was taken but was elevated as the patient was in pain and taking ibuprofen, which can elevate blood pressure. There's a dermatology visit for a rash where blood pressure was not checked. There's a telehealth follow-up with a psychiatrist for prescription management when blood pressure wasn't checked. I've taken December 31st as an example to show you how ridiculous the quality measure is. In all of these examples, it is your PCP who fails the measure. We are putting the responsibility of the entire medical establishment on PCPs. No wonder PCPs are burning out and leaving in droves. And to make matters worse, home BP logs cannot be used. And patients need another billable visit to document a normal blood pressure, which means that the patient incurs another copay or deductible. We have created a system where we are pitting providers against patients instead of helping create a more healing environment. Despite randomized controlled trials showing a mortality benefit from tight blood pressure control, implementing such targets as quality measures raises concerns about overtreatment. Inaccurate blood pressure measurements, white coat hypertension, white pulse pressure, or other issues in everyday practice can lead to excessive medication use, resulting in hypertension and other adverse effects. While evidence of harm remains largely anecdotal, it highlights the need to test these quality measures in real-world clinical trials before widespread implementation. Paradoxically, busier or poorly trained providers are more likely to over-medicate than higher-performing practices. Therefore, the quality measure can potentially harm patients and promote mediocrity over excellence. Now that we understand the challenges with this quality measure, let us look at some strategies to improve performance. These strategies assume that a patient's blood pressure is controlled at home. The strategy to improve performance can be divided into two categories: collecting and documenting of blood pressure data, and submitting data. Let's redesign the office workflow to better collect blood pressure data. The office staff needs to be trained to measure blood pressure properly. While PCPs in some specialist offices such as cardiology and nephrology that manage hypertension generally train their staff well, this can be an issue in other specialist offices. Create a protocol for staff to repeat blood pressure if the first blood pressure reading is high. In many offices, doctors run behind and the patient is waiting in the exam room. Use this to your advantage. The second blood pressure reading is generally lower as people are less anxious and feel like the staff and doctors did not forget about them. People with white coat hypertension or those with normal blood pressure readings at home should check their blood pressure at home on the morning of their office visit. Use this value instead of the spurious high office blood pressure reading when documenting blood pressure reading in the vital section of the electronic health record. Now, this is a gray area not clearly spelled out in the quality measure specifications, and it is open to interpretation. And make sure that you document that this blood pressure was done at home and not in the office. If a person has orthostatic hypertension, use sitting or standing blood pressure values, which will be lower. For telehealth workflow, the staff needs to check if any patient with upcoming telehealth visit have a diagnosis of hypertension. They should call the patient and have them check their blood pressure prior to the visit. Once the patient joins the call, the staff documents the blood pressure in the chart. This protocol should be used for all visits irrespective of the visit type as much as possible. Since only the last qualifying encounter of the year is used as the numerator, PCPs and ACOs need a workflow to ensure that the last blood pressure of the year is documented as normal. In order to do this, PCPs or the ACO needs an electronic data warehouse or a population health IT platform. The entire process starts with an accurate list of all attributed patients. If you don't know what attributed patients are, please watch my prior video, Who's Your PCP? The IT platform should collect blood pressure data from all qualifying encounters. Identify all attributed patients with a blood pressure greater than 140/90. Then the ACO care coordinators or the PCP office should contact these patients to schedule appointments, preferably in December, and document the blood pressure. Then you pray that the attributed patients don't have another qualifying encounter with a specialist, and if they do, the blood pressure is done and is documented as normal. If the patient does have an encounter with a specialist in which either blood pressure is not taken or is elevated, the IT platform should send a real-time alert to the care coordinators or PCP office to contact the patient and schedule another qualifying encounter visit, that is, another billable visit in which a blood pressure can be taken and documented. Once we have collected the data, it needs to be submitted to the insurance companies. Controlling blood pressure is another quality measure that is now an ECQM standard, and therefore a QRDA3 file needs to be submitted from the provider electronic health record or the ACO IT platform. Also remember, if a specialist does not submit a QRDA3 file but had a qualifying encounter, the PCP is considered non-compliant. As part of the ECQM, CPT2 codes will no longer be accepted, but some plans may still accept them, so keep submitting them for now. And lastly, the PCP office or ACO can run reports from the electronic data warehouse or population health platform, format them per pair dictated formats in CSV Excel, and then submit them. NCQA's requirement for a blood pressure of less than 140/90 during the year's final encounter illustrates Goodhart's law perfectly. When a measure becomes a target, it ceases to be a good measure. This quality measure has forced PCPs and ACOs to improve the statistic, not by controlling blood pressure, but by ensuring that data collection and submission workflow is in place. And by doing this, the controlling blood pressure quality measure has increased the administrative burden and costs, not just for PCPs, but also for patients, with the potential for over-medicating patients whose blood pressure is already controlled, leading to side effects. And all this time, it penalizes physicians who work with populations with social determinant of health needs. These physicians then burn out and stop taking care of the very population that the quality measure is trying to help. End result? The blood pressure numbers will look better, but there won't be any difference in cardiovascular deaths. Goodhart's law at its finest. You can find a written version with references to the material and audio podcast version on pcplens.com. If you like this video, please sign up on pcplens.com so that you don't miss the next episode when it's published. Thank you for watching, take care, and goodbye.